We'd like to welcome you to the treatment and care session for this afternoon. My name is Nicole Shears. I'm a respiratory physiotherapist and an early career researcher at the Institute for Breathing and Sleep and University of Melbourne. And my co-chair this afternoon is Andrew Tossolini, who's a senior researcher from University of Queensland. In this session, we have 3 keynotes and 5 platform presentations, which will be the same format as last session, which are the 12 minutes and 3 minutes for question time. And so we're going to start with Dr. Colin Mahoney, who's a neurologist, was trained in the UK, did his postdoc in ALS in Sydney, and now directs the Cognitive Disorders Clinic at Liverpool and supports the multidisciplinary MND service there. And Colin's going to talk to us about current trials in Australia and their respective stages. Thank you, Colin.
Thanks, Nicole, for the introduction, and thanks for the invite to give this talk. I gave this talk last year in Brisbane, and I'm pleased to say that there's been some positive news since then with some advances. But like some of the other speakers this morning, I would probably start with some acknowledgements, mainly to the people in the room living with motor neuron disease, their families and carers, because clinical trials just aren't possible without your participation. And we ask you to take drugs and treatments, many of which have been hashed out in the drug discovery phases that we've heard so much about today, but sometimes to take treatments which are untested, untried, come with risks, often come with significant interventions like lumbar punctures, and you do it all selflessly, repeatedly, and I think that, and with altruism, often knowing it may not affect you, but those who might come after you. So really warm and deep appreciation from those of us in the trial space for doing that. So I will try and work this thing. We did a little demo earlier, maybe. Okay, yeah. So I set the scene for what is a clinical trial the last time I gave this talk, and I think it's important because it puts it into perspective how difficult it is to get a drug from concept to regulatory approval. But broadly speaking, a trial is research. It involves people and it involves an intervention, and we're trying to firstly assess, is a therapy safe? And then we're trying to assess, does it make a meaningful difference to an individual? We typically use placebos, so these are, they can come in different forms, but they're compared against an active ingredient or an IP. And then we look at outcomes, which are usually defined before the trial starts, to see if that outcome is achieved. At that stage, then it will move on to the next phase, which really takes anywhere between 10 up to 15 years to go through these pipelines. So many years devoted to actually identifying the pathways and the pathophysiology of a disease before it will get into phase 1, which is really about safety, and then moving through different larger, more demanding and more expensive phases before a drug gets approved. So what is currently approved? So we've heard this morning a great talk by Rick Bedlack, who, here we go, who mentioned some of the drugs that are now on the market. So Riluzole has been around since about 1994, 1995. It has a modest but consistent benefit on disease survival. And as we heard, 80–90% of our patients choose to take this drug. And in Australia, it's relatively easy. There's still some hang-ups from how it was originally approved by the TGA about spirometry. These are probably rubbish and don't need to be there anymore, but they're still there. And most patients will be on this. And indeed, most trials now ask for patients to be on it before they commence the next inclusion into another trial. Edaravone, which has also been around for around, well, not quite as long, maybe 5 to 10 years, depending on jurisdictions, not currently available in Australia, though I've certainly had patients who we've managed to source it from Japan and provide private infusion services to deliver this therapy. It seems to have most of its benefit in early disease or in people with milder impairment, but it's very difficult to administer. And there is now a fully enrolled trial of oral edaravone. I think that will be really exciting to see the readout of that trial, because I think it may allow regulators to look at it again, particularly in Australia, and that might be a therapy that we see very soon coming. We heard about Relyvrio, which is this combination therapy with sodium phenylbutyrate and Tucta, which was approved last year in the US, isn't available in Australia. And as we heard this morning, it was really approved on the basis of fairly modest clinical efficacy. So one of the requirements is that there's an ongoing trial. And again, the readout of that trial will come probably 24. Incredibly expensive, $158,000 per patient per year. In the US, those prices may have come down a little bit, but that will be a significant barrier to the PBS here in Australia. There's some interesting data that will probably start coming through about high-dose Tucta on its own. We know some of these therapies that are being developed are therapies that have been around a long time and they're being repurposed. And you know, we don't really know with the individual ingredients how they work. So I think there is some more science to be done here, but potentially more cost-effective ways may come to deliver some of these active ingredients. And then we also heard about tofersen, which again was proved on the basis of some surrogate biomarkers showing a reduction in mutant SOD1 in the spinal fluid of individuals. It didn't meet its endpoint, as we heard, but I think that gave confidence to the FDA to approve it. And really a recurring theme across, I do trials not just in motor neuron disease, but in Alzheimer's, and a recurring theme is that really early treatment is critical for all neurodegenerative disease. So the FDA have kind of bought into this. We probably need the TGA to buy into this as well. But we have to be careful about managing those risks and benefits. Tofersen is an intrathecal product that's given through the spinal fluid. There are extended access programs available for these drugs, and I'll mention a bit about EAPs towards the end, but these are ways of accessing therapies which aren't currently approved by the TGA in Australia. I think, as I was saying, Riluzole is the only TGA approved. So whatever treatment in Australia, we have to give that caveat. So anything that's discussed beyond that, we always recommend patients discuss it with their doctors before pursuing any specific treatments, because some things do have side effects. But one, I suppose, call to action I would make to those people in the room who are concerned about the lack of access is we really need to put pressure on regulators in Australia. I've trained in the UK, US, and Ireland, and the systems of drug approvals are way too slow in Australia. They don't really want to acknowledge decisions made in other jurisdictions, which I think particularly for rare diseases and diseases with rapid disease progression, we need to be putting more pressure on the TGA, on our politicians to do this. So patients are and their families are the best advocates. I know MND Australia do it as well, and clinicians need to do it as well. But that's a real, you know, having worked in other jurisdictions, it is ridiculous that we have only one drug approved when there's 4 others approved in other jurisdictions. The challenge of ALS, as we've heard a bit about today, is the fact that its pathology and pathophysiology is complex. So we talk about cellular excitotoxicity, we talk about neuroinflammation, and we talk about what's happening actually at the muscle itself. So whether there's issues with contractility of muscle fibers and muscle metabolism. So there's many different, and we've heard a lot, and I won't rehash the disease mechanisms, but there's many different processes. And every time we try a drug, we're usually just tapping into one of those pathways. And that seems to be futile across the degenerative space. We need trials that actually look at targeting multiple pathways simultaneously. And that's one of the reasons why riluzole is really mandated as a requirement for most trials now. Like this clicker is kind of having the same post-lunch slump that most of you are having. Let's see, but we'll keep going. Okay, so there were a number of failures, unfortunately, in the last 12 months. So Neurome, which was a patient-derived stem therapy, slightly modified, a large study. There was a signal in early disease, so it may come back to another trial, but unclear at the moment. The trial itself recruited people with probably more significant disease than previous trials. Meridian, we heard, I think just before lunch, some talk about complement, and we had 2 negative trials using complement inhibitors. So Meridian looked at pegcetacoplan, which is a C3, complement C3 inhibitor. And then last year we had ravulizumab, which also was a negative trial. These are relatively early phase studies, so they may come back again. They may come back. The RAP ALS study, which was a small phase 2 study, but again, looking at different disease pathways, looking at particularly signaling pathways like mTOR, it didn't really do what they wanted it to do from a proof of concept point of view. So that was another negative study. We've heard about the Healy platform at Mass General in the US, and there was unfortunately, again, some of the trials have cycled through that now, have come back negative. Verdiperstat, which is a myeloperoxidase inhibitor, was negative, and Brodopidine may have a benefit, may have had some signal of benefit in terms of bulbar symptoms. So the drug company is looking at doing an independent study of this, but nothing has been decided yet. A study I was involved in, the Courage ALS study. This is a drug that looks at muscle contractility. That was stopped early because of futility analysis. And then the Focus C9 study, which was an antisense oligonucleotide study, also unfortunately didn't meet its endpoint and was stopped. Though again, a signal was seen in this with target engagement, and particularly in CSF of patients with C9 mutations, reduction in poly-GPs, which is thought to be a surrogate of disease pathology. Another trial that I was involved in, the nanocrystalline gold, or CNM AU8, which was supported by Clean and FightMND. Australia was the first site to perform a trial, but the Healy platform also used CNM AU8 as well, larger study there. Though neither trial met its endpoint, and this was a phase 2 study, there were a number of secondary endpoints which were positive. So open label extension continues with this study actually. From our cohort in Sydney, 90% of patients actually got through that 36-week period and onto the open label extension. And there's been further analysis as the OLE has gone on. And really, I think what the graph here on the hazard ratios here on the left show is that the dashed line are people who started on placebo, and the solid line on top is people who started on active. And you can see that by I think 2.5 years or so, there was a significant difference in survival benefit. So you're about 50% more likely to be alive. You're about 60% more likely to be alive, and about 50% compared to historical controls. So we need a larger phase 3 study, and that's planned. Some trials recruiting in Australia. I'll just briefly whiz through these. The Lighthouse study, which is utilizing Triamec, Ambroxol, which is a high-dose cough medication that's being trialed in Sydney. The Cardinal study, which is a medication that's directed towards oxidative stress, is currently recruiting. A study of Monapantal, which similarly to rapamycin may have an effect on mTOR, and a small phase 1 trial is planned for that. But really the biggest change has been this change towards precision medicine. We've heard a lot about treatment failures, and we don't always understand the reason for those failures. And in many cases, it's down to differences in patients, and really trying to more precisely target the right drugs to the right patients has to be an ongoing focus. So we're now moving towards platform trials where we can do that. And the initiative here in Australia has been the All-Star clinical trials. And this is the first platform study in Australia. And the first drug that's going to be used is lithium, a previous failure, but was found to be positive in a group of patients. So we'll see what comes from that. I mentioned about extended access programs, and these are increasingly being utilized by drug companies as a way to get more data. I guess be careful about this, but always speak to your doctor about potentially having access to a drug outside a clinical trial and outside an approved pathway. So the last slide I'll just mention is the challenges and opportunities we have. I think I've mentioned just drug studies, and we're going to hear some other interventions outside of drugs, which it's very important to remember symptomatic treatments because they can make a huge difference for patients. We need to recruit earlier. We need to get patients into studies earlier. We need to be mindful of what patients and their families want and need and expect. So patient-reported outcome measures have to become really embedded in trials. We have to get more patients into trials. My last two things won't come, but what I was trying to say at the end, here we go. We have about 2.5% to 5% of patients with ALS getting into trials. We need more than that. So we need this last picture here that I'll just explain is the number of patients needed in a trial to demonstrate a meaningful outcome. And depending on what measure you need either more than 200 or 500 patients for a trial to actually demonstrate efficacy. And most of the dots there are trials less than that. So we may well be underpowering our trials. So really a call to those involved in the trial space and treating patients to really advertise trials to your patients, and they will make the decision if it's right for them. Thank you.
Okay, we'll have time for one quick question if anyone has anything.
Thank you, Colin. Brilliant overview. When you're talking about that trial, patient recruitment into trial, I think a lot of trials look to recruit patients, say, within 2 years of diagnosis. That probably is quite a limiting factor. Is there more scope, do you think, to expand sort of the inclusion criteria to help with that recruitment? And should companies be looking at that?
Yeah, and that's where really I think some of the extension studies, particularly the phase 4 studies where we have an approved drug, and I think the FDA have recognized this in Alzheimer's disease as well, that we need real world data. So trials are trials, they're artificial, they're not the kind of the reality we live in. So I think looking towards those phase 4 type studies would be a way to address that. But going back to what I said earlier, I don't think the real change will come by treating somebody 2 or 3 years into the disease. We have to find better ways of diagnosing neurodegenerative disease almost pre-symptomatically. Now, how we do that's a challenge for everybody. There's cleverer people in the room that are probably working on biomarkers of this than me. But now, again, I give the reference back to Alzheimer's disease, where we have pre-symptomatic biomarkers. We need to be working towards that, I think, because that's where we will make a difference, I think, if we can treat early, not late.
Okay, next up we have Dr. Karen Hutchinson, who's a research fellow and physio at Macquarie University, and her talk is Barriers and Enablers to Implementing a Motor Neuron Disease Multidisciplinary Clinic in Regional New South Wales.
Thank you for the opportunity for presenting this research today. This research is actually being conducted in the Central Coast Local Health District, and I am still a practicing physiotherapist as well. I'd like to thank the Central Coast Local Health District for the small grant that has supported this research today. Here we go. So this is a basic overview of my presentation today. And I'd like to start with this quote. Without context, words and actions have no meaning. So I would first like to set the scene. We've already heard some contextual information from other people today, and I want to sort of bring it back to the Australian context. So the current research and the MND guidelines prioritise the need for, oh, hold on a second, little technical issue. Right, thank you. So let me just start again. The current research and the MND guidelines, which come from the UK, Canada, and New Zealand, optimise the care and support for people living with MND to optimise care for them in the community to increase timely access to access to care, and also to improve timely access to disease-modifying treatments such as non-invasive ventilation. And Dr. Marnie Greco will be presenting that information next. However, this is challenging within the siloed funding models that we have in Australia, which is based on age rather than diagnosis, which is creating inequitable and fragmented access to vital care. So the NDIS is non-means tested, and for those 65 years and under. And My Aged Care is for is means tested and is for those 65 years and above. And again, as I mentioned, is based on age rather than disability. We've also got the clinics. So the specialised clinics are mainly city-based, which can be a barrier to people attending in person from regional and rural and remote areas. And sometimes they lack the contextual understanding of where people live, and some of the, and there can be some communication issues back to the community teams. But we do have telehealth, which is a growing opportunity in that space. So this study is about exploring the barriers and enablers to implementing a regional-based motor neuron disease clinic. And you can read the rest. It is based in the Central Coast, which is 1.5 hours north of Sydney, and it's the area that spans between Newcastle and Sydney. So currently, we've had a clinic that runs 3 times a year, no out-of-pocket cost to the person. We've had 12 clinics since February 2020, which is a fairly significant time of the year, of years, because of post-fires, and then we also had COVID-19 hit. And we have thankfully been able to hold all clinics despite COVID-19. We've had 35 people with MND have attended, and with the frequencies range from 1 to 12 clinics. We've got an age range of 40 to 85 years, and we've 25 males and 10 females, and 12 of the people that have attended have been NDIS funded, which highlights that many are living with the My Aged Care funding. So, okay, this is a very busy and complex looking picture, and it is not comprehensive. It just gives you an overview of the many supports and services that people living with MND have to navigate, and within the community, and within local health districts, and within specialist services. And also I'd like to sort of comment that the fact that people living in rural and regional areas have got very limited access to services and support, which is why I've added the travel and the accommodation planning for some of those that to actually access the care. We've also got internet challenges in rural and regional areas. So sometimes telehealth, some people have to go to their local health centres to actually access that. So I'd like the clinic that we're about to talk about is actually located within the community. It's not attached to the health system. And I'd like to introduce Flora, who's 42 years old, who lives with MND and has 2 teenage children. So this is basic overview of the clinic as it stands now. It was set up using the Just Do It approach, because after negotiations with public health, and they weren't going anywhere, it was a case of the people in the community were asking for services local to, closer to home. So this is the neurologist set this up. So the clinic started with 2 sessions in the morning and now has extended to a whole day, 3 times a year. And as you can see, there's various steps that people have to take to go. They have to be referred to the clinic. And then luckily we've got some very good administration staff who actually help with this. And we have the palliative care specialist and occasionally the respiratory specialist who come on board through telehealth. So the evaluation of the clinic, we've conducted semi-structured interviews with those working in the clinic and those attending the clinic. And we've used a thematic analysis, both inductive and deductive, underpinned by the theoretical domains framework and the COMBI. And we've held 2 stakeholder advisory groups to inform the research design and progress. For those, the theoretical domains framework, there are 14 domains and you can see them on the right-hand side and how they relate to the COMBI, where capability, motivation and opportunity, this slide outlines the connections there. So I want to go over some of the key enablers. So we all agree that multidisciplinary input is always beneficial. We've got clinical expertise, so we all work with people with MND. We have years of experience. And one of the patients said he's got the best team as in professional. We've got great examples of transdisciplinary working. When I haven't been able to attend, the speech pathologist would do some nutrition screening for me and vice versa. We've got great examples of interprofessional collaboration. We know each other, we know our professions, we know how each other works. We've got great clinical leadership, who's a strong advocate for the clinic and also a really open person. We've got connecting to services. We've brought carer support into the clinic. So it's good that the carer support unit is there. I can reach out to them. We've also providing person and family centred care because we've got MND New South Wales staff who attend and they're integral to the real life problem solving. We've got the clinics allowing prioritisation for MND. We've got people who are working in this space with passion and we're doing it on a voluntary basis rather than financial benefit. And we're optimistic about the introduction of new services into the clinic and hopefully people feel more empowered. It is their clinic so they can make suggestions and help to evolve the clinic. We've got really good admin support and we've got really great trusting relationships and everybody's thoughts and opinions are valued and people feel equal and get equal quality care and support. We've got barriers. We have low medical specialist representation in the clinic. And for the team that are there, they really want access to the respiratory physician and palliative care. They're the teams we find it harder to connect with. We've got limited time invested as clinic is unpaid work. So the healthcare professionals that attend the clinic are doing it without being paid. And that really does affect the investment of time and effort. Health is not engaged in the clinic, but we are working on that and they don't recognize the value. There's communication both ways can work better. And as I already said, nobody is paid to attend the clinic, but the social care professionals who do attend are actually employed. They get paid because that's part of their role. We've got conflict of interest to the code of conduct. It can't cross boundaries and paths. So we've got some people who work in the public health system and in private, and they have to only attend in the private capacity. And the main barrier is being held off-site in a private practice. So what do we know? We've got multi-dimensional challenges. We've got inequitable care. We've got complex needs. We've got disconnected services. We've got system barriers. We've got challenging funding models, and we've got challenges with geographical location. But the clinic is helping to raise awareness of the needs of people with MND. We are looking at person-centered care. We're developing great workarounds. We're bridging service gaps. Really great examples of caring and goodwill. We're listening to needs and also good examples of team and transdisciplinary working. So yes, the clinic has challenges. So we don't have any funding. There's no staff reimbursement. We've got public health staff restrictions. We've got limited coordinating and connected care. We have no access to electronic medical records. We're competing paid work commitments. There's lack of specialists attendance, and we've got limited staff capacity building opportunities, which is needed in the public health sector and in the private sector. So overall, oh, sorry, we've got that one. Capabilities, we've got knowledgeable, skilled team, great transdisciplinary working within the local context, and we understand that context, and there's lots of workarounds. We are, despite not being paid, we are still providing quality, equitable, person-centered care. We're raising awareness of need, and we're meeting a demand. So we're a growing service, even despite, so people keep coming back. So that tells you that obviously we're doing something right. We have strong positive ties to the community, and we've got great relationships that we're building. So going back to that very busy, complex model, so we've highlighted service gaps and care inequities. So the clinic that sits in the local health system, local community, we're looking at how we could possibly move that into the public health space so we can actually have more staff. We can access electronic medical records, we can have specialists attend, but we still need to be able to work across sectors, and there's not a quick fix to that. So this is the other solution that we're looking at, is co-design and implementing an integrated MND care coordinator role that's person-centered, networked, integrated, equitable, and looks at the context. And this can help with the timely access to expert care, improve care experiences, and help to build the capacity of the workforce and raise awareness of MND. We know we're in a competitive environment. We're competing for funding, clients. Many people coexist. Lots of organizations coexist. They're not working together. But the clinic is having conversations. We are building cooperation through the this research as well. We're bringing people together, and these are the areas that we need to target: coordination, collaboration, and integration. But it takes time and resources to invest in building new ways of working that are successful in connecting and coordinating care. So we need to co-design this process to develop the intervention. We want everyone involved to develop the what. And we need the people who are using the services, the deliverers, the supporters, and we need to continue to build relationships and connections. So planning for implementation of an intervention to ensure success, adoption, implementation, sustainability, and scale up is not a quick process. And these are some of the steps that we need to sort of look at and things that we need to do to ensure that we deliver something that is needed. I'd like to just finish with this quote. It's probably a sense of relief for some of these participants, not just participants, but their family, to know that they have got that support of the clinic and that they have that option at least. It's working as a team. It doesn't matter what body, organization, bucket of funding, whether it's health, whether it's community team, NDIS, you're still working for the same cause, and you're still working towards better outcomes for that participant. And I'd like to thank everybody involved and the passion of everybody that's working in this space and the people that contributed. Thank you.
We have time for one or two quick questions for Dr. Hutchinson.
So, how are you going to move it into the public sector then? If you don't go via the coordinator role, is there?
Well, we're waiting on the palliative care team are very keen, and we're waiting for some potential New South Wales palliative care funding, but we're not sure when that's going to happen or if that's going to happen. But the clinic has been included in a grant opportunity with that.
So is the obstacle from New South Wales Health just it will cost them money?
Sorry?
Is the obstacle from New South Wales Health their unwillingness to move it across just because it will cost money?
And yeah, and it's all the governance and all the organizational stuff and so that we can actually work with PHNs, we can work, you know, the primary health networks. We need to be able to move across systems. It's a system issue. And we have people that are agreed to the model and they are really excited about maybe translating to other neuroprogressive conditions, having the clinic once a month. But having it smaller so that people pop in, but the amount of resources they're going to provide is would be fairly limited. So they recognize that it's important, but yes, how we're going to do that, it takes planning and lots of discussions, but we are having those conversations. So that's what we're here for.
I think in the interest of time, we'll move on. Thank you, Dr. Hutchinson.
Thank you.
Next up, we have Dr. Marnie Greco, who's talking about understanding the uptake of non-invasive ventilation in MND, results of a national survey.
Thanks, Andrew, for the introduction, and thanks in particular to the programming committee for putting me after Karen. It's really the perfect segue for my talk. So, oh, have I gone too far? No. So my talk today is about non-invasive ventilation. For those who are perhaps not so familiar with non-invasive ventilation, you may have heard of it as BiPAP. It's a machine that supports declining respiratory function by delivering pressurized air via a mask. It's a highly effective treatment that improves sleep, symptoms of breathlessness and fatigue, quality of life, and also survival in motor neuron disease. However, the best available data that we have suggests that the uptake and the use of NIV in Australia is low. So if these 10 people down the bottom represent the people living with motor neuron disease in Australia, we might. The data from our old registry, that's now about 10 years old, suggests that only 1 in 5 people with MND in Australia are ever trying non-invasive ventilation. And of those, just 50% of those are not using it to the degree that they're supposed to. So at this point, I just want to make the comment that we are not expecting 100% uptake of non-invasive ventilation. To not use NIV is a perfectly valid choice for many people with motor neuron disease, but we do believe that a 20% uptake is far too low. There are data from overseas that suggest that it's more like 60+%, and that's what we would be aiming for. So I was lucky enough to receive a postdoctoral fellowship through Motor Neuron Disease Research Australia to try and address this problem. And these are the 3 objectives that I'm trying to address in the fellowship. And today I am presenting for the first time the results of the first study, which was a national survey to estimate the rates of NIV uptake in Australia, and in particular the patient and disease level factors that were associated with uptake. Before I do, I just want to acknowledge these wonderful people on the slide who are supporting this program of research. So this is my stakeholder advisory group with representation from across Australia. We have MND researchers, MND clinicians, and most importantly, people with the lived experience of motor neuron disease. So our survey, it was an online survey that was designed to be completed by the person living with motor neuron disease or the person caring for someone with motor neuron disease, but not both. It was a snapshot, so this was a cross-sectional study of the population living with motor neuron disease at the time that the survey was open. So people from a whole, I guess, in completely different stages of their disease. It was distributed via emails from the state-based MND associations and also advertised via social media and with flyers in clinical areas. And we designed the survey to be as brief as possible to maximise our completion rates. And we offered participants the opportunity to have support to complete it over the phone or with an interpreter. So this is some of the advertising material. Hopefully many of you have seen this when the survey was open. And now I'll present the results. So we had 224 people with MND complete the survey, or their carers, which represents about 10% of the population. And part A of the survey were 4 very simple questions that were designed to provide this information about people's use and access to non-invasive ventilation. So of the respondents, we had 46% who said that they were using NIV at the time of completion. 6% had started and stopped. 4% had been referred and were waiting to start NIV. And then of the remaining participants, there were 32, so 14% of the total sample, who had discussed non-invasive ventilation with a health professional, and 58, so 25% of the total sample, who said that they had not discussed NIV with a health professional. So 201 went on to complete the demographic questions, and I'll just briefly summarise those. So we had 64, the average age was 64, 62% male. They were median 2 years post-diagnosis. We had most living in a metropolitan area, and there was variable responses by state. So we had great response from Victoria and WA, for example, but unfortunately very low response from South Australia and Tasmania. And most participants were living at home with their spouse or family member. And so we hypothesised that many of those demographic variables would be associated with NIV uptake and use. And so we used that data to test this. So we defined 2 outcome variables. The first was whether people were currently using NIV at the time of completing the survey. And the second was whether or not they had been offered and accepted non-invasive ventilation. So currently using NIV is the blue there were 44%. And whether or not they'd been offered and accepted NIV also included the group in the brown, which were those who had stopped, and also the green group, who were those who were waiting for a referral. And we looked at those independent predictors. So we first tested every variable one by one. And I know there's a lot of numbers on this slide, but let me talk you through it. So what we found was that the green variables here were significantly associated with using non-invasive ventilation. So women were less likely to be using NIV than men. People attending a multidisciplinary clinic were more likely to be using NIV than those who weren't, and people living in Victoria were significantly more likely to be using NIV. The variables in yellow, whilst not significantly significant, were certainly trending in the way that we had predicted. And so you can see there, for example, the age of over 65, and we cut it at 65 deliberately because you've just heard Karen talk about the fact that the NDIS funding, it cuts out at 65, and we thought that this might have an impact. And you can see that age for those over 65 was lower than those under 65. And same for living alone, people living alone were less likely to use it. We then, to control for confounding, we then plugged all of these variables into a multivariate model. And the variables that remained significant were living in Victoria. So people living in Victoria were significantly more likely to be using non-invasive ventilation than those living we excluded Tasmania and South Australia, so Queensland, New South Wales and WA. And people who were living alone were significantly less likely to be using non-invasive ventilation. So now for the second outcome, which was what we defined as NIV uptake, so those who had been offered and accepted a trial of non-invasive ventilation. What we found with this analysis was that, again, being female was associated with poor NIV uptake. Time since diagnosis, which makes sense, so the longer you are from your diagnosis, the more likely you were to have been offered and accepted non-invasive ventilation, and also where you lived, so how remote you were. With metropolitan having the highest uptake and rural and remote having the lowest uptake. And we certainly heard that with Karen's talk as well. So again, there were some other variables that behaved the way we thought, but not quite statistically significant, but worthy of further investigation. So they were age over 65, attending an MDC, and the state that you live in. So again, we plugged these into a multivariate model, and the variables in this model that remained significant were being female. So your odds of using NIV were half of those males in the sample, And then also that degree of remoteness. So people who were living in rural and remote areas had a significantly lower rate of uptake compared to those in metropolitan areas. So part B of the survey was to understand people's experiences of accessing non-invasive ventilation, and the questions people were asked depended very much on the answers to their first 4 questions. And I'm just going to talk you through some of the results of part B. So firstly, people were asked which health professionals that they talked with about NIV before they decided to try it. And they could select more than one. So the average number of health professionals that people selected was 1.6. And you can see there that the health professionals they were most likely to help to talk about NIV with was respiratory physicians, followed by neurologists, and then followed by some allied health professionals. They were asked who helped them decide, those who had decided, asked who helped decide whether or not to try non-invasive ventilation. And the most common response was the doctor, followed by the carer and other health professionals. People were asked what their main reason for deciding to try NIV was. And the majority said that both relieving symptoms now and also providing longer term improvements, such as survival benefit, were equally important. But if you were to choose, for those who chose only one or the other, they were more likely to seek relief from their symptoms now rather than be motivated by those longer term benefits. And finally, they were asked how much control they felt over the decision to try NIV. And overwhelmingly, so over 3/4 of the respondents said that they either had a lot of control or complete control over this decision. So there are a number of limitations to this study which need to be acknowledged. Firstly, as I said before, this was a snapshot of the population living with MND at the time of the survey, and it wouldn't be appropriate for all of those people to have been offered or on NIV at that particular time. We also think there's a strong likelihood of a responder bias, whereby people who are using NIV, who are engaged in the health system, were more likely to respond to the survey. And so I guess for these 2 reasons, we really can't draw any conclusions about what the uptake of NIV is in this country at this point in time. We'll need to wait a few years to get data from the MINDOS registry to properly answer that question. We had a fairly low response rate overall, but particularly low response rate from South Australia and Tasmania, so we don't really know what's going on there. And we also had low numbers of people who spoke a language other than English. And although we adjusted for confounding in our multivariate model, of course, there's always the opportunity that there were things that we haven't measured that we've been unable to account for. So what can we conclude from this study despite these limitations? I think there are, many people in the MND community who have known for a long time or suspected for a long time that there is an equity issue around who gets non-invasive ventilation and who doesn't. And I think these data provide evidence for the first time that there is indeed an equity issue in this country. So I think we can confidently say that NIV uptake is related to where people live, including their state and how far away they are from a metropolitan area, their gender, with women being less likely than men, and who they live with. So people who live at home with family, for example, are much more likely to be able to use this therapy, which makes sense. I also think that there's reasonable evidence to suggest that it may also be related to attending a multidisciplinary clinic and your age being either over or under 65. So what next for this research? First of all, there's more analysis to do in this survey, haven't finished yet, but we are currently conducting a couple of qualitative studies where we are interviewing people with motor neuron disease and their families about their experience of accessing non-invasive ventilation, whether or not they use it or have even heard of it. We're really keen to speak to people. And we're also interviewing health professionals who are responsible for referring patients for NIV to get a more detailed understanding, a more nuanced understanding of the barriers that they're experiencing. And when we have all this information, we put it all together, we'll be able to work with the community in the next couple of years to help co-design some solutions to the problems that we find. And so finally, if there's anyone, I guess, in the audience who would be willing to participate in this research or to help in any way, We've got a QR code there, which leads you to a phone number. There's also an email, and we've got a number of flyers around, or please feel free to talk to myself or Kate or anyone in our team.
Thanks very much, Marnie. Questions, Jane? She was quick off the mark.
Fantastic speech, Marnie. It's NIV and BiPAP machines is one of the most commonly spoke about things at our support groups. I'm just interested as to whether you have looked into or are going to look into the actual access to the machines. It's one of the things we find, particularly for over 65s and in the regional areas, the machines just aren't out there.
Yep, absolutely, and we are. So we are currently collecting, or have collected, and are compiling data of around how the actual machine is provided and funded in every jurisdiction in Australia. And let me say, it's different almost everywhere you go. So, and I think there are, completely different models of how A, the care is provided, B, the machine is provided. And so yes, we are, and we'll be putting all that together as well as part of that kind of, let's put all the information in a pile and work out what are the issues that we can actually address to improve this problem.
And we're just going to take one last question.
I'm just curious to know if you have a thought or a hypothesis as to why females are more likely to decline.
Yep. So that one was one that I was a little surprised about until I stopped and thought about it. Everything else we'd kind of predicted. And so I think that there is just a general equity issue around provision of treatment for women versus men. And we don't know why that is. We've got some hypotheses which need to be tested in our qualitative study, and also I need to go back to the literature to look at that. But I think there are data showing that even for PEGs, women are less likely to receive care than men. Whether or not there's a referral bias, or whether it's because they're declining the therapy because they don't want to be a burden on their family, they're less likely to have kind of a carer at home perhaps that is willing to provide all of that additional support that's needed for non-invasive ventilation, and perhaps the other way. So yeah, there's a couple of theories there, but we really want to look into that and see if there's anything we can do to address that problem.
Thank you. Stuffed everything up. All right. And so now I'd like to welcome Alicia Gibb to the stage, who is the Equipment Service Manager at MND New South Wales, and she will be talking to us about cost effectiveness and sustainability of an equipment loan library for people living with MND.
Thank you for the opportunity to speak today. As mentioned, I'm from FlexiQuip, which is a service provided under MND New South Wales. Okay, so an overview of my presentation is up on the screen. My primary focuses for today will be on looking at the access to equipment or assistive technology for people with MND, looking at the quality of life surrounding the use of assistive technology, and also the cost effectiveness and environmental sustainability of using something like an equipment service for hire or loan versus single-use equipment. Starting with some background, so some of you may already be aware, but MND New South Wales provides information, support, education and equipment for people living within New South Wales, the ACT and the Northern Territory. So to give some context, the combined population of New South Wales and the ACT is 8.6 million people spread out over 800 square kilometres. By comparison, the population of the Northern Territory, where we provide support, is 250,000 people spread out over 1.25 million square kilometres. So it's a huge geographical area. So MND New South Wales do provide many supports, but the primary focus of today will be focusing on the equipment loan library called FlexiQuip that's based in Sydney. So over the last financial year, M&D New South Wales have provided services to 753 participants across primarily New South Wales and the ACT, but there have been a few people in the Northern Territory. So the average age of participants that we're providing a service to is 65 years of age. And as has been mentioned in the previous two talks, there is a massive difference and inequity between the NDIS system for under 65s and the My Aged Care system for over 65s. So M&D organisations throughout New South Wales do have, throughout Australia, do have differences in the way each of the states run their services, but the primary focus is on providing support and assistive technology. I will draw on some comparisons to M&D Victoria today, who we do work quite closely with as well. So let's start by what we know about M&D and assistive technology. So we all acknowledge that people with M&D experience changes in their function, resulting in a need for assistive technology. There is lots of research demonstrating the improvements in quality of life for people with a disability who have access to assistive technology. However, access is often very costly and can often be delayed through funding schemes. So the progressive nature of M&D isn't conducive to waiting weeks and sometimes years for funding models to provide assistance with funding assistive technology. So when a person is needing assistive technology, they're needing it now to improve their quality of life and their safety. So irrespective of a person's age, what we do know is that from diagnosis through to a person's death, they need a lot of assistive technology, and the assistive technology changes at different stages of the disease. So to overcome some of these access problems, FlexiQuip was established to provide assistive technology to people with M&D. So M&D New South Wales first established an equipment loan service in 1981, and it started with just 4 manual wheelchairs. Over the last 42 years, it's grown to be a significant equipment pool and was rebranded to the name of FlexiQuip 10 years ago. So FlexiQuip is surrounded by its equipment library, so it's for hire and loan of equipment, and its primary focus is providing a responsive service to people living with M&D. So we do have other organisations throughout M&D organisations throughout Australia who provide a similar service, but New South Wales and Victoria are the two largest services in Australia and are two of the largest non-for-profit services providing equipment. So the aim of the equipment library through FlexiQuip is to provide people living with M&D timely access to equipment, to improve quality of life through the use of the assistive technology, to meet the high and changing needs of equipment, and to provide it in a way that is cost effective and environmentally sustainable. Okay, so a review of the FlexiQuip service was completed over the last financial year. So within this 12-month period, we looked at what are the benefits to people with M&D and other progressive neurological conditions accessing assistive technology through this model of care of a hired or loaned service. So the results I'm about to talk about are all based on this same 12-month period and have a focus on quality of life, cost effectiveness, and environmental sustainability. So as of the 30th of June this year, FlexiQuip had 2,284 pieces of equipment in the library worth over $4 million. So FlexiQuip in both New South Wales and Victoria provide both low and high cost equipment with a focus on improving people's quality of life and improving activities of daily living in a safe manner. So as you can see on the graph, FlexiQuip has grown substantially. So we've grown by 49% in a 3-year period. And this has been really, really important to make sure that equipment can get out to people very quickly, and we have the stock availability to swap equipment over as people's needs change. So within this review period, we provided the 2,786 items of equipment to 465 different individuals, as I said, primarily across New South Wales and the ACT, but there were a few people in the Northern Territory. So of these people, there was a number of people that carried over the equipment prior to last financial year and used the equipment longer term. But there was also 1,840 new items of equipment that were provided just in this 12-month period. So equipment needs of people with MND from diagnosis to death vary considerably based on the phenotype and the rate of progression. However, on average, people accessing FlexiQuip required 8 pieces of equipment within this 12-month period. And this varied greatly. We had many people requiring just 1 piece of equipment, and we had people requiring up to 34 pieces of equipment within a 12-month period. So interestingly, what we did find is that people under the age of 65 years of age had higher assistive technology needs through this hired system, whereas, and they were needing 13 pieces of equipment on average, whereas in comparison, people over the age of 65 were only loaning 8 pieces of equipment. So what does an equipment service of this size all cost? So now that we have an idea of how extensive the equipment pool is in states like New South Wales and Victoria, I wanted to highlight the cost effectiveness of this model of care. So of the equipment that we provided, so the 2,786 pieces, if this had have been purchased as single-use equipment, it would have been a massive $4.6 million, whether that be to funding agencies, people themselves, other government bodies. So it's a huge amount of equipment. So what we also know is that only 43% of our funding is through the National Disability Insurance Scheme. So of the 43% of people that we were able to access some funding from NDIS, we were charging up to $2,500 per quarter for access to all of the equipment that they need from within FlexiQuip. The other 57% of people will fall under the aged care system, and unfortunately the aged care system doesn't provide enough access to funding for care, let alone equipment. So this 57% of people that were accessing equipment was through donations, trusts, private M&D grants, other funding grants, and requests. So like with any organisation, there's also expenses to run an equipment service of this size. The major expense that we have is the wages of 5 part-time staff members, which I won't disclose in this forum. We also have another major running cost being the purchase of new equipment. Now this varies from year to year based on access to grants and donations. The next major cost for us is due to our large geographical location that I was talking about earlier. We've spent nearly $250,000 just on couriers to get this equipment out to people. In an attempt to reduce some of these courier fees and better manage the way we're delivering equipment, we will be getting our own van from next year to do our own local metropolitan deliveries in an attempt to reduce costs. The next major cost is the repairs and maintenance, and this is at $73,000, and this is down on previous years because we have had an injection of new equipment. So by comparison, even without knowing the nitty-gritty of wages and the exact equipment costs, we can all clearly see that this is considerably more value for money when $4.6 million of equipment was provided. So I'll now move on to the environmental sustainability benefits of having an equipment loan pool. So in a world of fast fashion and single-use items, we don't want disability equipment to be adding to landfill. Hence the importance of accessing hired equipment, which can meet the needs of multiple people with MND and not just a single user. So with FlexiQuip's model of care, equipment's able to be returned and cleaned and reallocated in a timely manner, which also significantly reduces landfill. Unfortunately, the type of waste we have up here on the screen, it's not isolated and it's a global problem. Much of this equipment could be better used by people in need rather than landfill. So FlexEquip are regularly offered donations of equipment, and a lot of that is in very good condition. Some of that has never been used due to the limitations of waiting for funding. People will pass away before they've even received the equipment. So of the 125 pieces of equipment we've received, they were worth $646,000 just in this 12-month period. This equipment has been divided into 2 pools of equipment. So 58 items went into our general equipment for everybody. And the other 67 items, which were worth $500,000, allowed us to establish a sub pool of equipment to use for people who are accessing NDIS funding to really drive home the cost benefits of using this model of care rather than continuing to purchase single-use items and add to landfill. Unfortunately, we aren't able to accept all equipment for many, many reasons. But if we aren't able to accept it, we'll either recommend other options for on donation, or we ourselves will on donate equipment when we are no longer able to use it. So we've donated a lot of our equipment up to the Northern Territory. So in the last financial year, we retired 323 items of equipment due to wear and tear. But we've also donated 26 items up to the Northern Territory worth $133,000. And this equipment's then been on donated into rural and remote communities. Within the Northern Territory, because there is such a large geographical area, we aren't able to provide the large items directly, but they come from the statewide service after we've made the donation up there. We do send smaller items though via post. So some of the take-home messages for today is that people living with MND have high and changing assistive technology needs throughout disease progression. The equipment loan pool offers an extensive option for cost effectiveness and environmental sustainability, whilst also getting equipment to people in a timely manner. So programs like FlexEquip are offered in other states and can be replicated on an international level as a financially and environmentally sustainable model of care. And I'd just like to acknowledge all the people that have donated to MND New South Wales, all the equipment that's been donated to us, and like to thank Fight MND for the grants that we've received.
Thank you very much. Any questions? We have some time. Like there's a pattern here.
Great job, Alicia. So if I understand correctly, then NDIS, they have their funding for the equipment, aged care, they have some funding, and then you make up the difference. So is that right, that no one will be left without equipment, even if they're unable to pay? Is that the case?
Yeah, so there's very little equipment comes from aged care because people are often choosing between, do they want a wheelchair to get to the doctor or an out the shower that week? It's that simple. There's just not enough funding to go around. So most of our aged care clients will access almost all of their equipment through us. Whilst it's meant to be for medium-term use, we're not going to go and take equipment out from under someone when there's no other funding source. And then NDIS, people may choose to hire equipment or purchase equipment, but there's a lot more access in that space than there is in the aged care space.
So no one goes without, basically?
No one goes without, yeah.
Thank you, nice talk. I was just wondering why you thought that people over the age of 65 had less access the equipment less than people under 65?
Personal theories is that unfortunately people over the age of 65, because they can't receive the care that they require in the home, not that's taken away from the equipment, when they can't get care in the home, people in that age group tend to be in residential aged care facilities quicker than what someone would be under NDIS funding into a supported disability accommodation. Because it's so much bigger than just the equipment, it's the daily care, it's you don't get 24-hour support under the aged care system, unfortunately. And then that equipment is obviously then provided within the aged care facility.
Thank you.
Okay, if we could thank Alicia. Okay, next we have Dr. Ben O'Mara and Dr. Matthew Harrison, and the title of the talk is Making Video Games More Inclusive for People Living with Motor Neuron Disease, a Scoping Review. Thank you.
Hello, thank you for having me here today. My name is Dr. Matthew Harrison, and I'm joined somewhere in cyberspace by Dr. Ben O'Mara, Dr. Kirsten Harley, and Dr. Natasha Dwyer, who are all watching right now. They've been texting me about my shirt being tucked in, so it's good to see. They've given me the thumbs up. I'm here today. It's a bit of an unusual talk, I think, for this conference. And at first, when I saw the program, I was like, oh, how do we fit in? But I've seen some really, really nice through lines about how we can really make life better for people. I think that's what unites everyone here. And so our angle is a little bit different. We're talking about how we can maintain joy and social connection through doing something that many people love, including myself. I'm a massive nerd. I love playing video games, but this way of using gaming for social connection. So I'm going to talk about making video games more inclusive for people living with motor neuron disease, a scoping review, which has been a passion project of the 4 members of our team for the past 3 years now. So I'm going to begin, I think we're going, by just talking about our personal stories and what drew us to this project. So I'm a teacher by trade, which is really interesting. And we've got my 3 colleagues who will share their stories as well. We'll talk about why a scoping review, and then we'll talk about what we actually found from our study. So we're going to begin with a video by Dr. Kirsten Harley, who's a colleague from the University of Sydney. Some of you may know Kirsten. She's a person living with motor neuron disease as well. I think a really good framing for this project, the why. And
my mom, sisters, and I enjoyed connecting by playing online Scrabble. During the year, my legs started cramping, then tripping and falling, which I managed to ignore until I fell 3 times during a short walk to a conference dinner. I saw my GP and she referred me to a neurologist for tests. The 7th of January 2013 is the day our lives were upended as my husband Denzel and I held hands in the neurologist's office, and she gave us the devastating news that I have motor neuron disease. The neurologist explained that death of the motor neurons causes our muscles to weaken and shrink, and we progressively lose the ability to move, speak, swallow, and breathe. The pace and order of change vary widely, but typically people die within 2 to 3 years. The clinic nurse eloquently described the edge of a disease. It is bring my strong, active body, so that now I can only move my face, can barely swallow, and can't speak or breathe. Tubes connect a ventilator and feeding machine to my curious cyborg body, and a team of carers provides round-the-clock care to keep me alive. I have always enjoyed playing games, but gaming has become more valuable to me as MND has taken many of the activities I previously enjoyed as well as control over much of my life. Both how and what I play has changed with my changing body. As my arms grew weaker, I needed armrests, cradling my arms to use a computer keyboard. and found it easier to manipulate an iPad on my lap. With increasing difficulty moving my hands, I transitioned to a smaller tablet and then phone, and abandoned games which required speed. Finally, I became unable to even tap or swipe the screen. For a while, I settled on giving suggestions as my husband and young daughter created fabulous worlds in Minecraft, where I shared the fun problem solving and appreciated the gorgeous design in a hands-free way, as our family bonded during collective games of Monument Valley. I now use a NeuroNode to operate my iPhone. Its electrodes are attached to the skin over a muscle and pick up the electrical signal my brain sends when I try to move. The signals are sent to my iPhone by Bluetooth and use the phone's inbuilt switch control function, so I can choose and use apps, including games, as well as typing text to speak. It's remarkable, life-transforming technology. Initially, I activated the NeuroNode with tiny thumb twitches. Now, being able to play games by wiggling my eyebrows is my superpower. I know anecdotally that others in the MND community appreciate the fun that video games can provide. It has been great working with Ben, Matt, and Tash to map out what the research tells us about how to make video games more inclusive for the MND community.
So Ben O'Mara, who some of you may know, working for MND Australia, said he's putting together a team to look at this. And obviously Kirsten is a wonderful researcher and has lived experience. And Tash and myself work in inclusive technology. As I mentioned, I'm a teacher. My research primarily looks at supporting kids with disabilities to be able to play games alongside their friends in school-based contexts. And Ben had reached out and said he needed someone who had knowledge of hardware and Tash has knowledge of software, and how we could look together to make games more accessible and to break down some of those barriers. There we go, line of sight. So if you're not familiar, there we go. If you're not familiar, a scoping review is a way of mapping past studies, evaluations, and other forms of evidence, any sort of evidence we can find. From research and practice that's looked at what helps make video games more fun and easier to play for people living with motor neuron disease. So we looked at studies from around the world. We looked at studies published in English between 2011 and July 2021 when we finished our search. And we actually wanted to really make sure we looked at the grey literature as well, because a lot of the experiences from people who are living with motor neuron disease is not captured in research, as a lot of people here would know. We wanted to find out what were people doing, because there's some really cool things happening in the grey literature that we're not capturing in the academic literature. So we were very busy. We started with 7,292 records. Very lucky to be supported by research librarians to help us with that. We got down to 82 papers, and then we started to look at the grey literature as well. So we looked at things like prototype evaluations, framework development, surveys, a lot from the health journals, a lot from computer science. Majority of the papers were quantitative in nature, which makes sense given the medical focus on motor neuron disease. And the grey literature was fantastic because it was filling in a lot of the gaps and questions we had. So what did we find? 7 of those 82 papers explored video games and involved people living with motor neuron disease. So it's very limited. So it's very much, there's a lot we don't know. There were major kinds of technology were the idea of augmented assist technology. A lot of the things we heard about from the library session just before mine being hacked and being used to play games, which I love. And the idea of video game software and hardware needing to have flexibility and accessibility, so to be able to change different levels, change the speed of the game. Kirsten showed how she's using turn-based games in the examples. There's a bit of an examination of the barriers around the technological, the physical, the social, and economic. When I think it's really exciting is when we start looking a bit more about the lived experience. So most studies demonstrate a sensitivity to the needs, which is really important to hear. The evidence suggests the major gap, though, that on qualitative research involving people living with motor neuron disease, how they felt, how they experienced gameplay, and what their ideas are to be able to design more inclusive games. There is a small growing evidence base suggesting playing games can reduce boredom, improve the quality of life, and connect with family and friends. And that's been my lived experience working with Kirsten and other people living with motor neuron disease in this space over the last 3 years. So just as an example, if you're not a massive nerd like myself, you may not be too familiar with video games. On the left-hand side, we have the seminal Master of Orion 2 from 1995. I am a child of the 90s. And you can see it's got large buttons. So someone using eye gaze technique, it's a turn-based strategy game where you can take, a bit like a board game, have turns, take turns. You can use eye tracking to be able to push those large buttons. That's far more inclusive than what you see on the other side here, which we had Kirsten actually try out with her technology, playing Diablo Immortal on a mobile phone, which is an action-based game. It's got small buttons. It's not designed for people who may be using alternative AAC. We have been very fortunate. We've received funding from Fight NMD to co-design pilot programs to explore how we can actually use gaming as a vehicle to maintain and hopefully address the idea of the social death, to make sure that we are thinking about how we can keep people connected with their loved ones. It's a focus on fun. It's the idea of user-centered perspectives and researching this and trying to learn how we can either mod existing hardware, which is my area of passion, or work with game developers to be able to reduce the barriers in what we're doing. If you'd like to learn a bit more about this, please come and see me afterwards. Thank you very much.
Very much, Matthew. We've got some time for questions.
Great talk. Thanks for that. So my question comes down to more the feasibility, because each person may have a different interest in games. So how are you going to apply this? Like, do you have to have a panel of 5 games or something that have different accessibilities for each person or something like that?
Yeah, great question. I actually said it to the kids. So I said, hey, you guys have figured out a way to play, Super Mario Brothers Wonder. And I don't like Mario. And that's the idea of user-centered. So the idea of how we can have customization and using things like Microsoft's Adaptive Controller, using things like eye gaze. The lesson I've learned working with children is you can't force someone to use a technology that doesn't work for them. The technology has to work for the individual. And then we start that as the starting point. What type of game do you want to play? What type of technology you want to use? And then that's our job, is to figure out how to make the two go together.
And one last question before we move on.
Sorry, when you're using eye gaze, have you found limitations between the different platforms of different brands, or Apple versus Windows?
We have just started with our advisory groups. The actual research with people, we haven't formally started. So in terms of clinical results, for lack of a better term, we haven't got that data yet. As someone who's used Tobii eye gaze, for example, to play, we have found gaps, particularly around, and it's interesting because it doesn't always work consistently with different games. Like, it could be the same settings, but the sensitivity settings in one game could be different from another game, and that impacts on how well you can play. That's just my own lived experiences. Kirsten's actually online watching, so if she can answer through the chat, maybe. I don't know if that's helpful.
Great, thanks. So join me in thanking Matthew and the team. So next up, we have Rebecca Francis, who is a speech therapist from Flinders, and she will be talking, her talk is Exploring Clinical Management of Cognitive and Behavioural Deficits in MND, a scoping review. Thank you.
Good afternoon. Thank you very much for the opportunity to present my research. It's part of my PhD project. and I'm investigating cognitive and behavioural change in motor neuron disease with an interest in how that impacts on swallowing. Thank you. One more slide. So I'd first just like to thank my supervisors and my co-author that I've teamed up with from the UK to work on this project. So two of my colleagues are, my supervisors are speech pathologists and the other is a psychologist in the UK. I'd also like to start by acknowledging the Kaurna people, who are the traditional owners of the lands where I work and live, and also pay my respects to the Indigenous people, the Darul people, where we're on today. So we're now becoming much more aware that motor neuron disease is a multi-systems disease, and we do know that cognitive decline is associated with motor neuron disease, with the literature suggesting that approximately half of people will experience either mild to moderate changes, and with about 35% of them being mild to moderate and up to about 15% receiving a diagnosis of a combined FTD MND. And we are actually seeing that there is quite a lot coming more to the forefront in this space, both within the published literature and also within professional development opportunities, even as most recently as this week, I attended a talk on cognitive changes in MND. From a speech pathologist point of view, I'm very interested in this because a lot of what we do within the MND space is we support people with their communication, and also to support people with their swallowing problems, known as dysphagia, and that's an area that I'm particularly interested in. And the management strategies that we implement all require cognitive engagement to enact. So whether or not that's implementing these high-tech devices, eye gaze technologies, or if it's about diet modification, where we're changing people's foods or explaining swallowing disorders to them, it does require cognitive capacity to understand and also to implement and to adhere to, I guess. So in 2021, I set out to investigate how cognitive decline in MND interacted with swallowing problems in dysphagia. And the answer is we actually don't know. There was no published literature that actually had those key terms in the search. But it's really important. And what we also need to know, sorry, hang on, no, that's right, I've gone too far. It's important to understand because we do know that cognitive change is linked to poorer prognosis, also treatment refusal, treatment adherence, increased caregiver burden when there's the presence of cognitive and behavioural change. And it also impacts on decision-making capacity. And that's not just decision-making capacity regarding medical interventions, but also for social decisions, financial decisions. And the current clinical guidelines do suggest that we should be screening for cognitive and behavioural changes early in disease and also at regular stages throughout disease progression. But what's less clear is what happens next. So how is cognitive and behavioural change managed in clinically? So the research aim of this current study that I've published is to summarise the clinical management approaches of cognitive and behavioural change in MND reported both in the peer-reviewed and the grey literature. We also chose a scoping review because of the ability that it gives you to look at all published and publicly available documents. So we really wanted to capture that. We did a database search in October 22, and then we also ran that search across Google and Google Scholar. We limited the search to English only. And because we wanted to capture what was happening kind of now, so there's contemporary care approaches, we limited the search from 2010 onwards. And we also wanted to cast the net very broad. So we, any search term that, all three of our search terms, if they were in there, they were basically included into for analysis. So you'll see that we went through just under 2,000 peer-reviewed papers. And within the grey literature, we identified about 160 articles. So after they were screened and the relevant papers were removed, we were left with 26 peer-reviewed articles and 8 documents that we included for analysis. And then we conducted a thematic analysis on this. So a busy slide, but I've kind of grouped this. So on the left, you'll see out of the original research primary data, you'll see that there were 5 research studies that actually generated evidence specific for an MND context. And then from there was also a dissertation case study and audit. So that was in the research primary data. In the non-primary data, they mainly consisted of literature reviews, which you'll see on the right of your slide. Under the other category, you'll see we had guidelines and educational resource and an abstract for a training material. But I want to draw your attention to the majority of studies actually came under expert commentary. We have in the grey literature, the 8 studies consisted of clinical guidelines, news articles, fact sheet, book, and a web page. So from this, we then did a thematic analysis. Looking at cognitive change and cognitive and behavioural change management. And from there, we came up with 6 themes which address this. So assessment, providing education, advanced care planning, adaptations of care, communication, and carer support. So I'm going to go through the findings of each of these themes now. Hopefully. So assessment. So all of these slides, just for ease of reading, are set out in the same way. So you'll see under assessment, 12 out of the 26 studies had something relevant to this theme. I've then further categorised into a specific strategy if they actually outlined a what to do or a general recommendation, which was more like you should do this, but nothing really specific about what to do. And you'll also note that all of these were enacted by a practitioner to a person with motor neuron disease. So the key points for this, I guess, when you think about assessment is that ongoing assessment is important. This was definitely highlighted in both the peer review and the grey literature. But we went looking for management and we were given assessment. So the literature was largely silent about the management beyond the assessment in this theme. But the grey literature probably did suggest that assessment was important, not just for recognising, but also supporting somebody to understand and cope with the disease. And I think Rachel actually highlighted that in her talk today, that it was important, those sort of next steps kind of things, which is important too. So the next theme was about providing education. So the key take-home messages from this theme is most of the studies and most of the included information here suggested that education be given to the carer. And with a goal to enabling a carer to understand the functional deficits to support their understanding of the disease. And I will highlight that the studies were drawn upon from the dementia literature rather than MND specific literature. Next one is advanced care planning. So again, this was consistent across the grey literature and the peer reviewed. The take-home message was that it was important to talk about conducting this early for decision making, and that was due to capacity. And one of the things that it suggested was if it was presented early as part of routine clinical practice, it would support the sensitivity of this topic. So bringing it up as sort of a routine thing that we talk about. I think when we talk about capacity for decision making, it's also very important to think of this from a medical decision making, but also from a financial and social decision making as well, which I mentioned earlier. And the key points of this is it allows people with MND to be very proactive in their care and their planning. Adaptations of care. So this theme basically means that what we would need to change in the presence of cognitive and behavioural changes within a person with motor neuron disease. And so some of the key points here were that we need to offer supportive communication, support decision making, make changes to the environment and address safety concerns. But a lot of this was around general recommendations without necessarily going into the how we go about doing this. And it's also important to note that a lot of the strategies that were described were coming from outside an M&D context. Communication was an interesting one because a lot of the literature was communication should be adjusted because communication is more difficult, but there was very little to support on how to adjust your communication. It also, there was suggestion that AAC is something to be factored into. However, cognitive and behavioural change does make implementation of AAC more difficult. And there were very few strategies available in the theme of communication to actually guide clinicians and families on how to make changes to communication to support the person with MND that may be having these cognitive changes. And the last theme is carer support, and there was much more in this space. And there were certainly more specific strategies that were researched in this space. And it was around carers being encouraged to consider their own needs and self-care. And again, Rachel touched on that, not making your life be all about MND and having that respite. And it was also talked about that carers need to be considered in the assessment and management. So, you know, thinking about the person that's looking after the person you're working with as well through all of that. So I guess the key findings, if I bring this all into a summary, is that mostly what's out there in the literature are general recommendations, and there's limited specific strategies which we can use to guide practice and also to guide families. The strategies are derived of expert commentary and sometimes drawn from evidence outside the MND context. And I guess the other thing that was interesting was that often the person with MND that has cognitive change is overlooked in management planning. So this review forms part of a larger research program, my PhD studies. So subsequently to this, I have been interviewing clinicians to understand what they're currently doing and their approaches to managing cognitive and behavioural change. And I've also spoken with many people with MND, both within Australia and overseas, which has been amazing, and asking them how they want this to be managed. So some key preliminary findings. Definitely that multi-D clinicians really valuing the interaction and the experiences of other clinicians. They lean on each other for support. And there was a real expressed need for guidance, which is embedded in an MND specific evidence. Additionally, families that I spoke to, they overwhelmingly told me that they want to know about these changes, but the timing of when this is shared with them and how it's done varies. And they certainly expressed to me that the journey from diagnosis to kind of what now is very overwhelming. And so therefore, you know, sometimes a little bit at the start is better than too much information. I'd like to leave you with a quote. This is something that really sticks in my mind. It's a lovely gentleman that I was interviewing, and I asked him, would you want to be told about cognitive change or cognitive changes if it was happening to you? And he said, Rebecca, well, I don't want to read half a bloody book. So thank you very much. There are some links there to my studies, and I welcome any questions.
Thank you, Rebecca. Any questions?
No, good.
Thanks, Beck.
Thanks. It was a really great talk. It sounds like there's a big gap in evidence in that area. So my question is, have you got any plans to look at developing or working with a group on a research project to sort of fill that gap?
Yeah, thank you. I definitely do. That will be sort of what I do post October 24th, 2024, when I finally press submit on this big journey that I've been on of my PhD. Just a side note that's popped into my head is I actually interviewed somebody that lives in an African continent, African country. I'm just trying to remember which one it was. But he has got quite a strong family history of MND, and he's very, very keen to set up an MND service over there because there is nothing. So that's certainly something that I would be love to talk to some people about and look at whether or not I can do anything with that. But as far as one of the questions I had when I was speaking with clinicians was, if we were to design a training manual, what would be in it? And so that's the data that I really want to take out of my, when I do my data analysis of all those clinician interviews and see where we can go from there to look at sort of designing that. Additionally, next year I'm planning to travel over to the UK to meet with the Mind toolkit developers. So Ratco, who was one of my co-authors, is part of that toolkit that they've been designing, and that was something that was in that review. So definitely wanting to sort of work with them as well. So
Hi. Lovely talk, thank you.
Thank you.
At the beginning, you were talking about the importance of continued assessment, and I was just wondering, are there standard assessments that are done for cognition with people with MND? Are they same as, you know, like with dementia, or are there different sort of tools that are used?
I actually had that in my slides and I took it out because I wanted to reduce clutter. So I'm glad you asked. But the validated tools are the ALS, CBS and the ECAS in the MND space. And they're the ones that came through very strongly in the literature of screening tools that could be used. Interestingly, though, in the NICE guidelines, it does actually recommend an RCT to look at whether or not screening actually improves care and what benefit there is, because obviously there's this huge gap in management. So by finding out and not knowing really what to do with it, I think we need to address that as well. So thank you. That's a great question. Thanks very much.
Okay, next we have Dr. Salma Charania, who will talk about speech-language pathology care in motor neuron disease.
All right. Well, first of all, I would like to thank the conference committee and MND Research Australia for inviting me to be one of the keynote speakers at this year's symposium. Okay. So today is going to be more of an education type presentation, specifically more about the role of speech pathology services within MND care. I'll be looking specifically at dysphagia and dysarthria, and I'll explain that a little bit more. And I'll also be focusing on voice banking, which is a type of management within speech pathology care in MND. And time permitting, because I may talk a little too much, I will talk about some future directions that I think are really interesting within the realm of speech pathology care. So we know that people with MND experience a variety of symptoms due to the progressive nature of the disease and deterioration of their body. Therefore, complex care is needed and requires a multidisciplinary team approach. While speech pathology is an important part of MND care, it's only a small aspect of care, which I really want to bring to the forefront, because communication and swallowing care requires an MDT approach. So in general, speech pathologists study, diagnose, treat communication disorders, including difficulties with speaking, listening, understanding language, reading, writing, social skills, stuttering, and using voice. People who experience difficulties swallowing food and drink can also be helped by speech pathologists. So that's just the scope of what we do. Now, within the MND space, our role is really to promote better living and quality of life within the realm of communication and swallowing. All right, so I will speak about dysphagia first. So as mentioned before in the previous presentation, dysphagia is a swallowing disorder. And over 80% of people with MND will experience dysphagia at some point in their journey with MND. That can lead to the risk of choking, aspiration pneumonia, so a chest infection, malnutrition, dehydration, and in some cases, premature death. It also introduces the risk of a reduced quality of life and impact on social relationships. Speech pathologists also address secretion issues with people with MND, but for the purposes of this presentation, I won't be discussing that, as the next presentation will be doing that. So I'm just going to give you a little bit of a background around a swallow and a very, very basic understanding. So we have 4 phases to our swallow. We have our anticipatory phase, our oral phase, or what I call our mouth phase, our pharyngeal phase, or what I call our throat phase, and then our esophageal phase. I'll just be talking about the oral and the pharyngeal phase. So when we eat and drink, we take a bite of the food, we close our mouths, I hope. We chew the food up, hoping that food comes out because we have enough lip strength. We chew. We have our saliva mixed in with the food. A bolus is formed in the middle of our tongue, and we're able to propel that food to the back of our mouth. That's all voluntary. So we get to choose to stop in the middle of chewing, maybe to have a little talk sometimes, unfortunately. And then we get to the pharyngeal phase. So that's when it gets to the point of the back of the throat. And that's actually an involuntary phase. So once it hits the point of the back of the mouth, our bodies take over. So you have the throat moving up and forward with the hope of deflecting a piece of cartilage called epiglottis over the airway, as well as propelling the food down into the esophagus and clearing any residue at the top of the throat. So very basic anatomy and function of the swallow. So with MND progression, these muscles start to lose strength and function. So some of the symptoms that may occur with dysphagia include food or fluid coming out of the nose. Okay, so that's nasal regurgitation, difficulty actually holding food or fluid in the mouth while chewing or drinking. So you can have that, what we call anterior spillage. So we can have food or fluid coming out of the mouth. Difficulty actually chewing and grinding up food safely. Having difficulty bringing the food from the front to the back of the mouth, initiating an actual swallow, propelling the food down with enough pressure, difficulty protecting the airway, so not being able to produce an effective cough in case food or fluid gets into your airway, and then difficulty in terms of clearing the airway, so having to take multiple swallows rather than 1 to 2 swallows to clear that, or sorry, the throat, I should say. So really quickly, I mean, in the context of research, this is more clinical, but basically when we do dysphagia assessment, we try to get a patient-reported outcomes measure. So one tool that is used is the eating assessment tool. It's a 10-question survey that looks at severity of different symptoms of dysphagia using a 4-point Likert scale. And a really low score is needed to indicate that there are symptoms of dysphagia. We also use a clinical bedside swallow evaluation, so that's just a subjective measure that the speech pathologist does, and it includes an oral motor assessment, so it includes looking at the muscles of the face. While it's gold standard to conduct instrumental assessment, it doesn't always happen, but 2 types of instrumental assessments include the video fluoroscopy swallow study and the flexible endoscopic evaluation of swallowing. The video fluoroscopy is essentially a moving X-ray where you can look at the oral, pharyngeal, and upper esophageal function during swallow, and it allows you to determine the presence, timing, and amount of aspiration. A nasoendoscopy can also be used. However, you don't get as full of a view of the swallow, but it does indicate whether or not aspiration has occurred. I've just put a little bit of an example for the next slide of what a X-ray of the swallow looks like. X-ray. Well, just kidding, you don't need to see it, but that's the X-ray. So usually what happens is it's live. So you'll see the food and fluid and how it goes down the throat and into the stomach. Oh, is it working? Yeah. Okay. That's what we call a normal swallow, so you don't see any residue. So as you can see there, even just basic anatomy, not having a speech pathology background or something, you can see that there's a lot of residue and it's actually not going down into the stomach appropriately. All right. So within the realm of speech, or within the realm of MND, the goal is to minimize the physical, emotional, and psychological impacts of dysphagia and to promote quality of life and safety in eating, drinking, and swallowing. This can be achieved through diet and fluid modification. So here we have the IDSI, or the International Dysphagia Diet Standardization Initiative. We can also help by managing fatigue, so reducing sizes of meals and having them more frequently, having your main meals when you're most alert. And then I put high calorie foods here, but that's a little bit of a sticky one, and it really requires collaboration with a dietitian, because it depends on the person with MND's presentation, how they're feeling, and what their needs are. You can use compensatory strategies to help with swallowing, so sitting upright and alert, having modified cutlery, having smaller bites of food or fluid, and if appropriate, a chin tuck as determined by your speech pathologist. But the main thing I want to put here is that all those compensatory strategies that I just listed require either occupational therapy and or physical therapist involvement. So when you want to sit upright and alert, if you have posture difficulties, you actually need a physiotherapist to then assist you in terms of the optimal position for them so that they're not experiencing pain while eating and drinking. Or if you need modified cutlery, an occupational therapist can actually assist you with that. So it is a really definitely an interdisciplinary approach. I also wanted to bring up here, and as previously mentioned, or it wasn't mentioned, but there is the option for risk feeding. So that's the acknowledgement that there are issues or there are consequences or risks to continuing with a certain diet or fluid consistency. So I won't go through the steps of what you should be doing in terms of determining that, but the main thing that I want to bring up here is that the person has to be of sound mind to make that decision. So if there is a presentation of cognitive difficulty, then it makes it more challenging to follow the wishes of the person with MND, and therefore you need to discuss it with your MDT and the carers of the people with MND. Now, another role that speech pathologists are involved in, but not central to, is the placement of the PEG. And that's to reduce risk of aspiration and or choking and to ensure adequate nutritional and hydrational needs are met. So the speech pathologist in a lot of cases, and at least in my experience, bring up and introduce the idea of the PEG because they're monitoring how the swallow is going. And so when there is an indication that the swallow is actually deteriorating to a point where it's no longer safe to have oral intake, a PEG would be necessary. With that being said, it's really important to introduce the PEG earlier on. So it's a fine balance, which I won't go into. It's also important to provide education on the PEG and to monitor for chest infections, weight loss, and the amount of time it takes to consume meals, fatigue, and distress. And again, like I've said before, liaising with the MDT. So now going on to dysarthria and MND. So dysarthria is an initial symptom for 25 to 30% of people with MND, and 80 to 95% of people with MND will experience some sort of dysarthria and difficulty communicating their needs using natural speech. In turn, they're likely to have an impact to their psychosocial well-being and reduce social relationships. There is also a correlation between speech impairment experienced by people with MND and a reduced quality of life. So dysarthria is a motor speech impairment characterized by difficulties executing and controlling motor speech production. And the features include decreased speed, range, tone, and/or steadiness of movement in the speech subsystems. Types of MND dysarthria initially include flaccid or spastic dysarthria, so characterized by weakness or a strained, straggled kind of speech voice. However, that becomes mixed later on. And that causes a reduction in intelligibility and eventual loss of speech. Now, I kind of worked backwards here. So normal speech, if you look at the diagram, consists of the 4 speech subsystems working together. So you have your respiratory subsystem, your phonatory subsystem or your voice, your articulatory subsystem, so that's your speech, and then your resonatory subsystem, which is the vibration you experience when you're speaking. So your respiration is your powerhouse for speech. So you take a deep breath in, and as the air is coming out, you're going to vibrate your vocal folds, which is going to cause voice. And then you're going to shape that voice with your articulators. So your mouth, your teeth, your tongue, your lips. And then that's what's going to create speech for you. So all those have to work together. So if one or more of those are impaired, that's when we're going to have difficulties in intelligibility. All right, I'm just going to skip through. All right, quickly, the way we assess dysarthria, a lot of the time it's been impairment based, but I really wanted to bring attention to the fact that while we're promoting a patient-centered care, it's important to use a biopsychosocial model such as the International Classification of Functioning and Disability, and that we're not just focusing on impairment, but we're focusing on activities and participation as part of the holistic care of people with MND. The one thing I wanted to bring attention to in this slide is that impairment in body functioning and structure does not necessarily indicate activity limitation or participation restriction. And that's evidenced by my findings from my PhD that actually people with spinal onset MND who didn't present with functional communication difficulties actually presented with reduced communication effectiveness. And there is also reduced psychosocial well-being in people who don't have communication difficulties related to communication. So it's really looking at the person as a whole when you're doing the assessment. All right, so with dysarthria management, education is really important. Again, I'm going to be speeding through because I'm clearly over time. Behavioral strategies, so instead of skipping right through to technology, a lot of the time people really want to keep speaking, so and helping them and endorsing that by giving them strategies such as exaggerated articulation, reducing the number of words per breath, using keywords, reducing background noise, gesturing, eye contact, and a big thing that I don't see out there in the literature is communication partner training. So how do we train communication partners to actually facilitate communication with people with MND rather than putting the whole onus on them. And then again, alternative and augmentative communication, so low versus high tech strategies. So low being paper-based, no battery, high being it needs a battery. So that could be pen and paper to write for low tech and say a smart phone for high tech. There's voice banking, which I'll touch on the next slide really quickly. And then other strategies that you could use our message banking, which I won't go further into, and then a digital legacy. So that's a free app that you can use on your phone or laptop, and you can record your legacy for your family. All right, so voice banking really quickly is a way of digitizing your voice. So essentially you're recording your voice, magic in the system of technology picks up your recorded sentences and then splices the phonemes. And then when you want to type out a new message on your device, essentially sticks those recorded phonemes together or sound bites together to create a synthesized version of your voice in real time. I hope that makes sense. So it's really interesting. The only thing is that it's not an exact version of your voice, but it allows you to produce messages in real time with the voice that sounds like you. So why is voice banking completed? So first, it's to preserve identity. and to maintain work networks and social networks, and also to help people with MND still have a sense of control. It's something they can do that's within their control. It's a type of insurance, so they may not need it, but at least they have something as a backup. It is also quite valuable for significant others. So a lot of the time, even the people I've worked with, when a client has passed, I've had families ask for their voices. So it does have an ongoing impact beyond using it on a device. The earlier you do it, the better, because you want to record your voice while it's still good. So if you record your voice when you have a dysarthria, that is the voice you'll get on your device. You need a computer, internet access, and a headset, which is really important. And you need a quiet environment and no background noise in order to finish the voice banking. How do you do the voice banking? Well, you choose a software, you obtain the necessary equipment, you write down personal phrases and add it to the software, you allocate time to record, and then you submit a request to do it. So it's pretty basic.
Sorry, Selma, in the interest of time, I'm going to ask whether or not if people might be able to come and contact you speak to you during the the afternoon tea break, or post some questions online, please.
So let me just do this. I do apologize that I went severely over time. Speech and swallowing is a difficult topic to get through, but I would love to talk to all of you about voice banking a little bit more. So please do approach me and I'd be very happy to answer any of your questions.
Okay. So for our final keynote speaker, I'm going to be introducing Charlotte Massey, who's a physiotherapist specialising in neuromuscular respiratory impairment. Charlotte is a physio who's worked at the Neuromuscular Complex Care Centre in Queen Square in London, and she's currently undertaking her PhD at the Sheffield Institute for Translational Neurology with Dr. Esther Hobson. Now, it is currently 4 a.m. in the UK, so Charlotte has kindly pre-recorded her presentation for us, so she doesn't have to present in her pajamas, but she will be online afterwards to do the questions at the end. So we're going to start that recording, please.
Hi everyone, my name's Charlotte. I'm a physiotherapist based at the Sheffield Institute for Translational Neuroscience and Sheffield Teaching Hospitals in the UK. I'm going to present today on cough and secretion management in MND, and this presentation was put together by myself and Dr. Esther Hobson, who's a consultant neurologist. So just to set the scene really, we know that saliva secretion and cough issues are really common in people with MND, and they have an impact on quality of life and affect the ability to give interventions such as non-invasive ventilation. They also increase the risk of chest infections. And recent research has shown us that up to 70% of patients with MND suffer with saliva and secretion issues. So it's a huge number of people, and it has a huge impact on their quality of life. And in the UK, back in 2019, we had this kind of NHS long-term plan, which talks about giving care to patients at the right time, at the right place, and giving the right care. Now, many of our patients often report difficulty accessing this specialist care outside of maybe a tertiary or a specialist MND centre. And most of this is because local teams are not as experienced in MND, and they might lack the skills and the coordination required to manage these really complex issues in this condition, with saliva secretion and cough issues being one of them. And I think we know that respiratory issues are a priority, and this work was actually done by MND Australia and showed that 67% of patients and healthcare professionals identified respiratory issues as a priority. So we know that these things are really high on the priority list for both patients and healthcare professionals. So if we think about the background of respiratory and cough impairment, we know that respiratory impairment is the leading cause of mortality or morbidity in people with MND. And cough impairment is a combination of lots of different factors. It's a combination of your inspiratory muscles being able to take a big breath in. Also your expiratory muscles, mainly your diaphragm, being able to force the air out to help you have a cough. And also, especially important in MND, is the impact of the bulbar function. And we'll talk about that in a little bit more detail later on. Now, the NICE guidelines, the most up-to-date ones that we have from 2016, tell us as physiotherapists to offer cough augmentation to people with MND who cannot cough effectively. So that is something that is offered. However, the guidelines are not very clear on exactly what that should be, how that should look like, and how you should adapt that for the individual patient. Much of the research currently around cough and cough augmentation in this field is based on a neuromuscular population as a whole. So many of these patients have things like muscular dystrophies, which present differently to MND. And often the upper airway is overlooked. And we know that this is really important in patients with MND because they often have upper airway or bulbar problems. And like I said, we'll talk about that in a little bit more detail later on. So if we then touch on saliva and secretion management, we know the research has told us that patients tell us that this impacts their quality of life. And also, as I touched on right at the beginning, the ability to be able to implement respiratory adjuncts. So that's things such as non-invasive ventilation. Also, things like we've just talked about, like things to help with your cough. So things like a cough assist may also be difficult to implement if somebody has got lots and lots of saliva in their mouth and they're unable to tolerate it. We know, especially all over, but that some of the research from the UK shows us that assessment and treatment remains really challenging, and across the UK, practice is really variable. So there's been a couple of recent kind of surveys that have had a look at what people are giving to support saliva and secretions within the UK, and actually we know that it varies hugely. So that's another issue. And there's also limited evidence on intervention. So many healthcare professionals don't actually know what is the best intervention to be giving at that time. Often as well, it takes numerous trials of different medications to get things right. And this can be really frustrating for patients. And then if we touch on multidisciplinary care, so we know that multidisciplinary care is beneficial. But we do know that there are challenges of it. And if we take cough and secretion management as an example, often there are numerous different healthcare professionals involved, maybe a physiotherapist, maybe a neurologist, maybe a respiratory doctor, maybe a nurse, maybe a speech and language therapist. And often the coordination and transition of care between these different professionals in different places can be challenging. We also, as I touched on at the beginning, a lot of specialist MND centres are in the middle of big cities, especially in the UK, which are quite difficult to travel to. People have to travel many miles, which is challenging as the disease progresses. And then that links with what we know in local services who may not see people with MND very often. The knowledge of skills of these specialist interventions and assessments is often limited. So what we're kind of looking at in Sheffield is we're looking at how we can support cough and secretion management utilising the MDT. And we know that it's really complex, so it's multifaceted, there's lots of different things involved and there's constant change. So as the disease progresses and muscle weakness evolves or changes, or bulbar weakness or spasticity changes, things can change. And if you look at the diagram here, there's a big interplay between all of these different things going on. So we have respiratory dysfunction. So that is weakness of your respiratory muscles. And that can occur at different times during the disease course. And often it's weakness of your diaphragm, weakness of your abdominal muscles that you have to brace against to cough, and weakness around here of your shoulder muscles that are also involved. And then we have to link that with bulbar dysfunction, and in a second I'll talk through exactly how we cough. But with our bulbar muscles here, there might be weakness of them, there might be problems with spasticity, so the muscles being tight and causing some spasms. And then the bulbar system here is involved in both speaking, swallowing and breathing. So it's really important, and the coordination between all of those different aspects is really key. So if these muscles aren't working properly, you may get an oropharyngeal dysphagia, so a problem swallowing. That can mean you get collection of food or drink or saliva in your mouth and throat or upper airway, which could go the wrong way and could go down onto your lungs, causing a chest infection. We also know that the impact of your glottis here in your throat can have an impact on cough, and I'll touch on how that works in a second. So these things are all hugely linked together. And then we have things on the other side. So we have things such as the ventilator that you might have. We have things such as cognitive or behavioural changes, weakness of neck muscles or postural posturing, upper limb dysfunction, so ability to use the hands to be able to feed yourself or use a cough assist or a similar device. And also loss of mobility. So if you're sitting in one position in a chair all day, obviously our lungs can expand a little bit less. So if we think about the upper respiratory tract, so almost we're putting things into, so we're thinking about this half first and then the lower half second. So we need to think about the importance of our nasal secretions. These trap inhaled non-infectious material. And then thinking about our normal processes. So normally if we had secretions in our throat, our body would feel them, we'd have a sensation of them, and we'd swallow them down, or we would cough them up. So if we have a little look at this video here, so this is a video of a normal swallow here. So we see here the patient's going to take something to eat here, and it's all gone down here, down the esophagus. Now, I'm not a speech therapist, so I'm not going to comment hugely on the swallow, but we see here a patient with an abnormal swallow, and we can see here that some of that liquid or food there is going down into their lungs, which has a huge impact if you then have a weakness of your cough. We also know that a normal adult produces about 500 mils of saliva per day, and this can increase when we're unwell. So if we think somebody has a problem with their swallowing and they're not able to swallow down that saliva, then that can be why we get accumulation of it in your mouth or in your throat. So then if we have a think about the lower respiratory tract, and I'm going to talk specifically here about the cough. So this is kind of your process of a cough. So you might get an irritation, something might go the wrong way. And then what happens is you take a big breath in. So normally that's about 95% of your total lung capacity. So you take a really big breath in and fill your lungs. Now, if you have any weakness of your breathing muscles, taking in that big breath is going to be very difficult. What happens then is this compression phase, and this is where the function of these bulbar muscles is really important, not only in the swallowing and the speaking, but also in the coughing. So what happens here is you get a compression. So your glottis closes over, and inside your lungs you get this compression of air. So the pressure builds up in there, and then you go to the expiration phase. So this is mostly controlled by your diaphragm, which is this muscle down here, and it braces against your abdominal muscles and pushes out that air really quickly. So a normal cough is around 75 miles an hour. At the same time, your bulbar muscles and your glottis has to open very quickly, and it narrows ever so slightly so that you can get more force out and try and clear whatever's there. Now, if we think there's any problems with the bulbar muscles, or any problems with the breathing in muscles, or any problems with the breathing out muscles, your cough will be affected. And we often talk about this difference between a reflexive cough and a voluntary cough. So a reflexive cough is where, as we've just discussed, something goes the wrong way and it's a reflex. Your body automatically coughs and to clear that thing. A voluntary cough is that cough when you might feel something's there, or you feel like you need to cough. And sometimes the planning of this cough can be difficult in people with MND. So sometimes the reflexive cough can feel stronger or different to the voluntary cough. And now we have to think about how the upper and the lower respiratory tracts interact. So as we've just talked about how a cough happens, we have to think if there's any problems with the upper respiratory tract here in those bulbar muscles, how might that impact what we want to do, and how might that impact a cough? And I'm going to touch on the work here by Tina Anderson, who's a physiotherapist in Norway, and she had a look at what happens to these bulbar muscles in people with ALS when we put on a device called a cough assist. And what you will see here, I'll talk through the video if we press play here. So what we'll see is on the left-hand side, she's got a picture of the cough assist that she's using. So this is a device, I'll just pause it there. This is a device where you might get this by your physio. It pushes air in to the lungs, and then it sucks air back out at a negative pressure. So positive pressure is pushed in, negative pressure is pulled out. And the aim of that is to support a cough. Now it's designed to help clear secretions from down in your lungs and bring them up so you can get rid of them out of your mouth. Now, what we know in ALS, and what is obvious with this, is that all of this air that's being pushed in at pressures has to pass through the upper respiratory tract first before it can get down to the lungs. And this is what she's showing here. She's showing what her settings are here. So we can just kind of ignore the settings to start with, but what we can think is that what's happening is she's pushing in air at a pressure into this person's lungs, and it's going through their upper airway. At the same time, they popped a camera in and they filmed what was going on in the upper airway. So in a second, they're going to show it in slow motion so we can see in a little bit easier. So if we see here, if we go back slightly, so this is the person's airway. It's nice and open there before they've started adding in the pressure. Now, as soon as we start to add in this pressure here, if we see here, we're there about 35 centimeters of water, we can see that the airway here has fully collapsed. So the pressure from that air going in has caused the upper airway to collapse. So no air is going down into the lungs. Whereas if we go back here before we started, this is your airway here. We can see the air is passing nicely in and out of the lungs there. So we'll go back here. So there we see the airway is collapsed. And then when she goes there to the negative pressure, it's a little bit more difficult to see whether the airway is open or not there. Let's see if we can see it here. You can see maybe slightly get a little bit of opening. Now, what they ask this patient to do now is just to breathe in on their own. So this patient is just breathing in on their own without the positive pressure. So if we see here, we can see the airway is nice and open there as the patient takes a big breath in. And then they've added on this negative pressure here to support the cough. and we can see that the airway manages to remain open as that's added in. So this is really important for us to be aware of, because if we are thinking about things that can help cough, we have to think about their impact on the upper airway. So if we think about impairments, and I think this is often how many physiotherapists or different professionals have a think, we think about what the impairment is. And if we think about secretions first, so we need to think about the impact of your airway diameter, so how big your airway is, on your mucociliary escalator, which is what's helping clear the secretions. We need to think about sensory recognition of secretions. So if somebody is constantly having secretions sitting in their throat, their sensation to them may reduce. So they may be able to build up more secretions before they feel it. We often talk about the importance of an expiratory flow bias in chest clearance. So that's very similar to what we just saw on the previous video, where the negative pressure is helping bring up, so an expiratory flow bias. And we need to think about the impact of chronic aspiration and recurrent respiratory tract infections on our epithelial and ciliary cells. So these are the cells that help kind of move secretions around within our lungs and within our airways. So if somebody is constantly aspirating bits of food or saliva and having recurrent chest infections, this can then impact on the way these cells move secretions around. And we've basically touched on the cough, so we really have to think about inspiratory muscle weakness, bulbar weakness, and the impact of that and expiratory muscle weakness. So when we're thinking about something to help somebody with a cough and secretion problem, we're having to consider lots of different factors. And I really like this practical guide, which came from a recent review article this year. It's from Gipsman et al. In 2023. And they talk about this practical guide to cough and secretion management. It's in people with neuromuscular disease, but it's really applicable across all of the diseases. So firstly, you have to consider what is being cleared. So what is it? Is it secretions from the chest? So phlegm? Is it saliva, runny saliva? Is it thick saliva? And then thinking about where did it come from? So has it come from the lungs? Has it come from the throat? Is it sitting in the mouth? And then thinking about what caused it. So if we're thinking where did it come from, it might have come from the throat, but it might have been that it's been caused by saliva in the mouth that has dripped down into the throat. So you're always trying to think about what's caused it. If it's chest secretions, what's caused that? Is that saliva dripping down, aspirating? Is it that somebody's food and drink is going the wrong way and they're actually getting that on their chest, which is causing chest secretions? Have they picked up an infection, a community-acquired infection? So constantly having to think, where did this come from and what's caused it? Where are the secretions? Exactly as we've just said. Where are they and where did they come from? And then lastly, which is really important, considering what we've just talked about, is what are that patient's specific airway clearance limitations? So when we're thinking about people with MND, is it that their breathing in muscles are weak and we need to help them with that? Is it that it's more their breathing out muscles that are weak and we need to help them with that? Is it a combination? Is it their bulbar function? So is it actually that their breathing muscles are not doing too badly, but it is the ability to close the glottis, open the glottis? And then also thinking from that side, how are their limitations going to impact the treatment that I give? So like we just saw with the previous video from Tina Anderson's work, often we might think, oh, the patient's got a problem with their breathing in muscles. I need to give them something to help with that. But actually giving them something to help with that may then impact their bulbar and glottic function, which then might mean that the treatment that you're giving is not working, which is what we saw in that video. So, oh, this patient's got problems with their inspiratory muscles, I'm going to give them a big breath in. And actually what happened was they were just getting no air in at all. So it was much less effective than them just taking a breath in on their own. And I just want to touch on a few resources. So these are resources that have come from the University of Sheffield. So we have firstly this new resource which is called NIV for MND, which has been developed over the past couple of years. So within that there are some advice videos on cough optimization, and this has been made for healthcare professionals, this website. And there's also a sister website that's been made for patients called My Breathing, and you've got little QR codes and links to them there. And My Breathing it's been designed by patients, and it's got patient videos in there. It talks a lot about how people have made decisions about what to support them with their breathing. So they're two really good resources that you can have a look at. Thank you very much for listening. There's a couple of key references that I've put in here, and I'm happy to take any questions. Many thanks.
Awesome. We do. So thank you very much, Charlotte, and for getting up in the middle of the morning to join us for the Q&A session, and to get us through these couple of technical difficulties that we thought we were going to overcome by pre-recording, but never mind. So if I just going to have time for a couple of quick questions before we close the session. Is there any questions from the floor?
Is there any danger of causing damage to the airways using the cough assist machines, especially perhaps if they're not being used properly at all?
Can you guys hear me okay?
Yes.
Yeah, perfect. I don't think that at the pressures that we use it at, there's any risk of the airway itself being damaged. So I wouldn't worry about that. The machines don't let us put the pressures high enough where we would cause any damage. However, we do have to think about the whether the intervention is actually working. So that's something that the video we just looked at, it's not causing any damage, but there's the risk that the intervention is not working. So that's what we're really keen to look at and is really key in what we're considering when we're giving a device like that.
And I think if I can just take on that as well, Charlotte, that what we know with the cough assist machines is that, as Charlotte was saying in that video, that if we don't titrate them very carefully, then we do see that closure of the upper airway. And so you do need to have quite there's quite a specialized sort of way of assessing that and working out exactly what settings on one of those devices you'd require to try and minimize that closure of the airway. And we know that by paying particular attention to that you can. And if I am, sorry, the respiratory physio in me is stepping in, but there is the risk of a pneumothorax for these things. So I'm just aware, Charlotte, if you want to speak to that, perhaps just mindful of we've got, people living with MND online and also some clinicians in the audience. If you might want to touch on the risk of a pneumothorax, please.
Yeah, so a pneumothorax is where you get a collection of air kind of outside of your lung. And because the collection of air is outside of the lung, it's kind of in the thoracic cavity, it can push the lung and cause problems breathing. So that is something, because we're pushing pressure in at a relatively high pressure, that there is a risk of that. So that is something that needs medical attention, and kind of it's sometimes a little bit difficult to recognize the symptoms of it, because a lot of the symptoms are around feeling breathless, which people may be feeling breathless anyway. So yeah, that's something that is a risk with this intervention, but it's something that we consider and we take into account when we're giving out the device. I don't know if there's anything else you want to add on that, Nicole.
No, Nicole says no. And one more question from online. Would you recommend use of a cough assist, given the video showing air may not be going into the lungs? Or is it more around considering reducing the inspiratory pressures versus the expiratory pressures?
Yeah, it's just, it's like Nicole's just said, really. So when a physiotherapist is giving a cough assist and they're aware that somebody has got some problems with their bulbar function, they are titrating the pressures and looking for lots of different things to make sure that the pressures are correct. So you know, reducing pressures, making the breath in a bit longer is often a good way to reduce that collapse. And actually with that video that we saw, they actually just took away that inspiratory pressure completely and just gave an expiratory pressure, which worked for that patient. So it's a really individual process, and we would always recommend considering a cough assist and giving it a try, and the physiotherapist working with the person with MND to try and optimize it as best as possible. The other thing to say is things might change as the disease progresses. So it might be that something works really well at one point and then has to be reviewed, and things might have to be adapted as the disease progresses.
Thank you very much, Charlotte.
Thanks.
And with that,
thank you, guys.
with that, we'd just like to close the session and thank again all the speakers for their time and energy. I've been informed that we're actually cancelling the afternoon tea. We're going to go straight into the next session. No, just joking.